I'm going to give it just a second to kind of get on people's screens before we start. Hello and welcome to the American Society of Regional Anesthesia and Pain podcast, Azra Wrap. I'm your host today, Raj Gupta, along with my co-host, Ketan Chopra. Ketan, how are you today?
Good. How you doing, Raj? Good to see you.
Doing excellent. Thank you. Great to talk with you always. And we've got a really fantastic show with two guests today. So we're going to get right to that in just a moment. I want to give a couple of announcements about upcoming things for Azra. Actually, the first thing I want to talk about is something that's already passed, which was the Azra Fall meeting. This was our first fully virtual meeting, and I think it went off just incredibly. I think when we looked at the attendance numbers for that meeting, it's the highest attended Azra Fall meeting to date, which was really surprising, exciting, and hopefully gives us some lessons for the future about how to make a hybrid meeting as we get back to real life sometime, hopefully next year. Speaking of next year, the Azra Spring meeting is going to be May 13th through the 15th. Everybody's crossing their fingers that it will be in person down in Lake Buena Vista, Florida. If that is not possible, we know how to do a virtual meeting, so keep your ears open and your emails on track to find out what the plans are for that. Very soon, you're going to be seeing notifications about submitting abstracts and registration opening. So I want you to pay attention to that. Regardless of how we get there, it's going to be an awesome meeting. Dr. Nabil El-Kasabani is the program chair, and I know he's been working incredibly hard for a long time trying to make sure that the content and speakers at this meeting are going to be out of this world. So look for that and more communication to come. So Ketan, I'm going to pass it over to you to introduce our first guest today. And I do want to remind the listeners that if you have a comment or a question, put it up in the comment field. We'll be seeing those in real time and trying to respond to them as best so that we can. The topics that we're going to discuss today, some of them can be controversial, so I ask people to be civil. I know that there's a lot of emotions about some of these topics, but we want to try to get the best information out to everybody out there so that people can learn and grow from this. So Ketan, I'll leave it up to you to introduce our first guest.
Right. Thanks, Raj. And I also just wanted to extend my commendations to the whole Azra team. It's not easy coordinating that many schedules and internet connections and getting everyone on the same sort of page for a virtual conference. So it was really great. It went off without a hitch. And for everyone who wants to watch it, you can just go on Azra's website or just Google Azra Fall 2020, and you should be able to check it out. All the lectures are available online. So one of the reasons Raj and I wanted to come on and do a podcast, other than the fact that it's been some time since we've been together, is to highlight some of the great lectures and speakers that were in the conference last month. And there were so many, and it was hard to really narrow things down. But we have two speakers today, which I think you'll all really enjoy. The first speaker that we have today is Dr. Chad Brummett. Chad Brummett is an associate professor at the University of Michigan, where he is the senior associate chair for research in the Department of Anesthesiology. He has greater than 185 publications, including articles in top journals such as JAMA, JAMA Surgery, Anesthesiology, and Annals of Surgery. He is the co-director of the Michigan Opioid Prescribing Engagement Network, also called the Michigan Open, which aims to apply a preventative approach to the opioid epidemic in the U.S. through appropriate prescribing after surgery, dentistry, and emergency medicine. In addition, his research interests include predictors of acute and chronic post-surgical pain, and he is the co-PI of 4 major NIH grants studying these concepts. And if that's not enough, he was also my attending when I was in fellowship. So great to see you, Dr. Brummett. How are you doing today?
Great to see you, Ketan. And I think it's a go blue moment for us because, Raj was a residency classmate here at Michigan. And, Ketan, you're one of our former fellows. So I'm feeling a lot of University of Michigan pride right now for all of my other Michigan fans out there.
Absolutely. It's good to be
Chad,
a Michigan
whenever
Wolverine.
we hear Yeah, Chad, whenever I hear your CV, though, you make me feel terribly inadequate considering we finished at the same time. You've accomplished about 5 times more than I have in the same amount of time. So I'm not sure what kind of energy level you have, but you're killing it. So
different paths, Raj, and really respect all that you're doing down there, both clinically, administratively, we all take different paths, and I think I spend less time taking care of patients than you do, and a whole lot less administrative time. So we all offer something to the organization, and the work you're doing with Azra is really impressive. So thank you.
Thanks.
Great. And before we started, even though this isn't a CME event or anything like that, Dr. Brummett, I'd like you to give the opportunity if there's any disclosures that you'd like to offer before we start.
Yeah, thanks. Even without CE, I like to be transparent. So I'm a consultant for Heron Therapeutics, Vertex Pharmaceuticals, and Alosa Health, and I do some expert testimony. I won't talk about any of those topics or products today. I don't do any promotional speaking, so it's pure consultative work. Thanks.
Great. Thank you for letting me know. All right, so just to start, you were a participant in the lecture titled Updated Opioid Use Realities. That was a great lecture. I recommend everyone watch that whenever they can. And obviously one of your great passions has been trying to manage the opioid crisis that we've been experiencing, and it's a great passion of yours. And you're the co-director of the Michigan Opioid Prescribing Engagement Network. I referenced that in your introduction, and I was wondering if you could just tell us a little bit more about that, how you got started with the initiative, what its objectives are, and kind of what its future is.
Thanks. So Michigan Open, even though I'm a chronic pain physician and all my clinical time currently is in the chronic pain clinic, I did OR for a number of years. I did acute pain service and regional anesthesia for a number of years, but really my clinical time has been reduced back to chronic pain. But Michigan Open we really came together at the end of 2015 and the beginning of 2016 to try to address what we viewed as a gap. And this was a partnership with the Department of Surgery, and specifically Mike Inglesby and Jen Walge, two colleagues and friends, surgeons here. Mike's a transplant surgeon and director of medical education for the medical school, and Jen Walge's a hand surgeon and a health services researcher, and just really one of the more effective people you'll ever meet in your life. And we really came together saying, the whole country at that time, and really you could even argue today, was focused on all the downstream effects of the opioid epidemic, what to do with chronic pain, how to deal with the chronic opioid use that we saw in our country, how to better address and treat and diagnose opioid use disorder and naloxone in the community, all things that I actually still believe are critical today. And in fact, Michigan Open has now moved into some of these spaces. But at that time, really, there were almost no recommendations or guidance on what to do for acute care, and acute care being surgery, dentistry, and emergency medicine. And nothing shows that more than the fact that in the CDC guidelines, there was one recommendation for acute care. It said, prescribe the lowest amount possible for the shortest amount of time possible. And that sounds great, but it's not evidence. It's not a real guideline, and it's really not all that helpful. It's a bit like getting a preoperative cardiology consult that says avoid hypotension, hypoxia, and tachycardia for this person with bad cardiac disease. It's an obvious, right? You're trying to do that every time. And I think we wanted to take advantage of a unique state platform. Our state's uniquely structured, and with a relationship with Blue Cross Blue Shield of Michigan, hospitals putting data into collaborative structures across the state, all 73 major hospitals throughout our state, and a partnership with Michigan Department of Health and Human Services, and trying to take this public-private partnership that really here at Michigan, we do try to embrace this idea of the university that we're here to serve the state, and we could come up with guidelines and recommendations that were less ivory tower driven, less based on expert opinion, and really based on real world prescribing, representing hospitals, large, small, academic, private, and a more diverse patient population, because we certainly hear that bias throughout all of our discussions around opioids. Well, those aren't my patients, or you can do that at the university because you've got residents or fellows that'll be there to backstop you. We're really thinking about this across all hospitals, all type, and trying to do something that should be translatable. And we already see it now scaling to multiple hospitals around the country.
Great. Yeah, and I think it's so important because one of the things that, well, I'm pretty fresh out of residency, and I can't tell you how many times after, laparoscopic surgery or something like that, I would hear the resident overhear them saying, "Oh, you'll go home with like 60 Norco," and it's like, man, that's like a lot. And I think that's what we've missed a lot in how this crisis started, is that a lot of times it's these opioid naive people who are given a substantial amount of opioids when they don't need it, and that's how the the dependence or what have you sort of develop. So it is a question I had, is there any specific, like, I don't know if algorithm is a word, but for specific surgeries, how much you're recommending, what medication you're recommending? Because I think there's a lot of people out there that obviously want to do the right and safe thing, but like you said, it's tough to know what exactly is the right and safe thing. So is there anything that U of M is doing in that respect?
Yeah, and so Michigan Open, we are a University of Michigan platform, but we have a statewide focus. We take that data and we update regularly. So we have recommendations on our website, michigan-open.org. It's michigan-open.org. You can go there. Those recommendations are updated regularly based on new data, because I think one key facet and one really differentiating factor for our group is that we didn't just sort of say, hey, we did this one quality improvement study at our one academic center, and this is how many pills to prescribe forever. The strongest predictor of how much a person is going to use after they leave the hospital is how much you give them at discharge. For every extra pill you prescribe, they'll use an extra half pill without any improvement in pain, satisfaction, or likelihood of refill. In fact, on the higher end, you may be increasing likelihood of refill because you're creating tolerance. And I'm not anti-opioid. I mean, despite what some people might say on Twitter, I'm not anti-opioid. These are a tool. They have a role. And so we have made recommendations on a range, and you'll see that our range is bookended with a 0. And I think that 0 is important and is a recent thing, because what we know is that, especially for inpatient surgery, if somebody's not using opioids before they go home in that 24 hours, they go home and they don't use any opioids. So why are we prescribing them? And I know now we have data. We've published articles in New England Journal and in BMJ Quality and Safety of the late, showing that we have decreased this prescribing without changing pain or satisfaction or refill requests across the state. You're talking about tens of thousands of people across 40 hospitals of all shapes and sizes, and without a perfect secret sauce. So there is no, here's the exact ERAS pathway, because if anybody's done high throughput implementation or trying to move things, if you walk in with a super rigorous algorithm, it just doesn't work. We have a group of surgeons who are engaged across our state who want to do the right thing for both healthcare and for patients. And you're right, we want to think about this not only in preventing opioid dependence, which is the most common complication after surgery. So becoming newly dependent opioids is definitely the most common complication after surgery, and our groups really contributed to that literature. But I think it goes beyond that, right? So there's a lot of morbidity that comes along with opioids that may have nothing to do with dependence or addiction, or right where people jump: nausea, vomiting, constipation. And if you don't need them, if there are surgeries for which you need little or none, then it's not just us being fearful of addiction. It's us thinking about you as a patient and avoiding morbidity. So we do have guidelines. We actually also have patient materials that we allow health systems to brand. You can send us a high resolution logo of your practice. We'll stick it on the front of these patient materials and send it back, and they're engaging and effective. So we've really got a lot of information on the website for people.
Hey, Ketan, I want to ask a quick question for Chad.
Absolutely.
Chad, and I'll break this up into 2 parts. One is that I want you to make the distinction for a lot of people between efforts to take people who are previously opioid naive and a lot of efforts to minimize their exposure to opioids as a prevention technique to prevent them from getting opioid dependent, and how we manage people who are already in chronic pain who are on existing opioid therapy. People think and conflate these 2 things and our management strategies the same, and they're not the same. And then the second part of the question is you mentioned the discharge prescribing of opioids after an acute event. But how far back are you reaching back to the beginning of the process, even before, during the pre-surgery planning period, and how that affects that whole course leading to that discharge prescribing?
Yeah, thanks, Raj. And so I would take this, taking it into 2, we are talking about 2 totally different cohorts. When you talk about a person using, there's actually, I would say 3 cohorts, right? Or 4 maybe. There's the opioid naive person not using opioids. We could separate that group into people with an opioid history or not. We can talk about that maybe later if we have time. But opioid naive patients, you have people coming in chronically using opioids in what I would call uncomplicated opioid dependence. That's the diagnosis, right? So there's no signs of addiction. And then you have opioid use disorder that I would break into 2 flavors. You have opioid use disorder for people in recovery, and those people might be using a medication like buprenorphine or methadone or naltrexone. And then you have people who have opioid use disorder that is either undiagnosed or untreated. And I'll just, to simplify this conversation, because the last category is certainly the most challenging, say that, really we have, our group tried to fill that gap of the person not using opioids pre-op, because if you go to your hospital on Monday, Raj, 80% of the people you're going to care for are not using opioids. And we weren't doing anything for that population. And yet, depending on your definition, and there's controversy in the literature as to what the definitions are. We've put some literature out there. There's really a lot of other smart people doing work in this space. But, it's definitely the most common complication. If you consider becoming newly dependent a complication, it's a complication. I think it's a complication. And the pathway for that's different, which it can include just not making opioids the sole tool, and setting the expectation, which leads into your next question, setting the expectation for patients about pain is a normal part of recovery. Pain is to be expected. We don't want it to be unmanaged, but opioids, when you call an opioid a painkiller, you ascribe overwhelming efficacy and benefit that's just not consistent with the data. Opioids don't fully kill pain. When you say that, you're telling this patient this is a powerful tool that's going to take away all your pain. Well, that's not really the goal for surgery, right? So if we think about surgery and pain as a normal coupling, and that it's going to get better over days, and we want you to be functional and we want you to rehabilitate, that's a more appropriate framing for people, and thinking about things like acetaminophen and ibuprofen as being really powerful tools and also managing that pain and recovery. The opioid tolerant patient coming in preoperatively is more complicated, and here you're going to find more expert opinion. People talk about this as though there's tremendous evidence. Our group is moving heavily into this space faster than I think we expected to. We have Mark Bickett, who just joined our group and is a new co-director of Michigan Open. He just joined us from Johns Hopkins. He and Jen Walgie are really starting to think about what is transitions of care for patients using opioids. And my fear is that we do have people who are being acutely withdrawn off of their opioids before surgery. Not a good path, not a good plan, right? All you're doing is probably making a person with mild withdrawal or moderate withdrawal before surgery. And as an anesthesiologist, I remember that, right? That's a hard thing. Now you're starting behind the 8 ball. And the whole path of preoperative opioid weaning is still a challenge and a question. And does it even help? So I think that it is critical, and probably would take a whole podcast, maybe we could do later, is to think about what do we do with these people using opiates beforehand, and how do we best manage a person with opioid use disorder? Maybe Mark or somebody or Jen Walgie would come on and do that. But yeah, I think they're totally different. And to your second question, which I already touched on, I think the most important thing we have to do is start to set expectations, right? To just frame the conversation. And I think when you do that, and when you have a path, and for a complicated patient, I think, again, this is about setting a pathway. We really believe in this idea of transitions of care, this idea that some people are going to be unexpectedly complicated, but honestly, a lot of the complicated people, you could pick them out pre-op. And I don't think everybody's got to have a transitional pain service because it's not scalable. Not everybody needs to see a pain physician because that's not scalable. But I do believe that identifying patients that are going to have those challenges and getting them coordinated for not only their pre-op, but for their post-op, post-discharge, will mean that on a Sunday, today, if I just drive down a mile down the street here to Michigan Medicine, there are people that will stay in the hospital an extra day just because nobody planned, right? And that's the kind of thing that we need to be doing a better job of.
Yeah, absolutely. And I think setting expectations is so important. Even as a fresh pain physician, I'd have patients who ask me, is this going to help me? Is this going to hurt? Now, you want them to feel good. You don't want them to say, oh, it's going to hurt or anything like that. But just, I tell them it might, and I don't know if it'll help, but it's just so important to be just honest. And speaking of patients who are on opioids, you mentioned that in your lecture that you actually recently helped someone in your life taper off a significant opioid regimen. And I'm in the private sector. I tend to get a lot of patients who are on a significant amount of opioids that were placed on them, not by myself, but by some provider that is now no longer willing to write them. And I'm not even sure where to begin sometimes with the conversation of tapering. I mean, it's one of those, words that we say that sounds great, and then you tell someone to taper off the opioids, but how do you do it? It's a very complex and tough topic. And I'm not asking for, the golden answer here, but how do you personally approach this type of situation? Any advice for those listening, any certain phrases or key things that you do, anything that you can give us, we'd be appreciative.
Yeah, I think it's a complicated conversation, and it does need to be tailored to the individual. This one was deep and personal because this is a close friend. This is a person who is very tough. I mean, this is a tough man. He is a new persistent user after surgery. surgery that was for cancer. So I think that we have a cancer exception. I'm not a person who believes that cancer patients should die in pain. I do believe opioids have a role in terminal cancer, but we have a lot of cancer that's curative. Cancer surgery that's curative, and yet we see huge portions of these patients end up. I mean, you're talking about maybe 5-10% of these patients becoming newly dependent after their cancer is gone. And I think that that's a combination of the expectation of the patient, the willingness of oncologists to prescribe, and also the patient's sort of sense that I have cancer, I should be on opioids. And this friend had been on them for a long time, very, very high doses, along with benzodiazepines, and had been cared for at a top tier medical center. But just once that happens, and he was not addicted. And I think that he has been in a position where he wanted to come off, and we have a gap. That gap is that people who are not addicted to opioids, so they don't have opioid use disorder, but have dependence, struggle to find a provider willing to take them off. And so what tips can I give? It's slow and low. For a person who's been on it for a really long time, 10% per month can be as slow as for some people. And you can imagine that curve starts to really level off. And so each month, less and less progress is being made. And I think some of this depends on the motivation of the person. And I think that, some of the things I really learned and I was aware of, but when it's personal, it's personal. And this was personal as a friend, is that it's not always just the physical withdrawal, but opioids really mess with emotion. And over time, they make depression and anxiety worse. But short term, and you see this postoperatively, you give somebody some opioid, it's not just the analgesia. You're allaying their anxiety. And that's mechanistic, right? Opioids allay anxiety. Over time, they make anxiety worse. But not surprisingly, then when you're weaning people off, depression, anxiety, and dark places. And I think this is where we're seeing suicide, right? Dark places are there. And so I think that this is a whole gap in our research, a whole gap in our understanding, and an incredible opportunity for people out there looking for a place to carve out a niche, is to understand how to better treat the very real and very profound mood disorders that come along with weaning. But it's slow, it's low. He was motivated, and it took more than a year. And he was highly motivated. I mean, I was having to pull him back at times, and it was still took a long time. And see the same thing for our patients. I think that when you're talking about your patients, the hardest piece is convincing them that you're not you're not a total nut job for saying you've got pain and I'm going to take you off your opioids. Because a lot of times you've maximized all the adjuncts. What else are you going to do for me? What are you going to give me? And the hardest thing, and I've done it, is look at them and say, I'm not going to give you anything else. And not because I'm mean, but because you've tried everything else. These opioids aren't working for you, and you're going to come off and you're going to feel better.
Yeah, that's such a tough
frequently
disconnect. Yeah, go ahead, Raj.
When I see some of my patients come in for the surgery, and we have a high-risk preoperative clinic where we see some complex patients getting ready for surgery. And just this week, I had conversations with patients who are on chronic opioids, Norco, 10 milligrams, 3, 4, 5 times a day. And I asked them, I was like, how long have you been on that? And they're like, oh, I've been on that for years. I was like, tell me the truth. Does it work? No, it doesn't work anymore. But they're still taking it, And so most people know that it's not helping them, but they also know they can't get off of them. And it's this weird trap they're in. And I think that the recognition of that is the first part of it, because there are patients I've talked to that have no sort of conscious awareness of that, even though they functionally know it. They have no conscious awareness of the fact that it's not helping them anymore. And like you said, taking it away is actually probably the best thing you can do to make their pain better.
Yeah, or at least not make it worse. And I think that's
Correct.
the thing to remember is there may be some people whose pain doesn't, we talk about opioid-induced hyperalgesia. If anybody's ever tried to do research on it, really hard to demonstrate clinically and to study clinically. It's actually a pretty clear preclinical model. And so I believe in it, but not everybody with opioid tolerance has hyperalgesia. So some people may not improve from that, but what will improve? Constipation, nausea, vomiting, fog, mood, taste. You'll start to all the experiences. And I think this is what was also clear. I've heard this from patients for years, but again, when you hear it from somebody you care a lot about, it's a different experience. And, my friend calling me and saying, hey, look, I feel like I've not felt in years. And so for people who have been rapidly weaned off or had the primary care physician pull it out from under their feet, they don't feel that. That is not because they were not prepared. They were not there. I know Beth Darnell talks a lot about this at Stanford. You got to prepare people and you got to make them willing and ready to do it. So.
Absolutely. And one of the last questions I think I had for you, Dr. Brummett, is that one of the medications that, as a fresh grad, I started learning more and more about is buprenorphine. I thought it was a newer med, but it's been out for some time, but I think it's kind of reintroduced itself into the realm of perioperative medicine and pain medicine a little more these days. Can you talk to us a little bit about the medication? What it's a very broad sort of question, but there's so much going around with it. Me and Raj were talking about it once, where we were trying to figure out what the best way is to manage these patients, even perioperatively. I think, 6 months or a year ago, the recommendation was to, wean them off of it and then restart it. But now we're saying continue it. So, talk to us a little bit about the medication, maybe clear up some misconceptions and tell us what you can.
So Bupe's an opioid. Buprenorphine is an opioid. It's an old drug. Everything you're seeing branded is just route of administration. So it's just a company that has come up with a new route of administration or delivery because of bioavailability. So I won't bore you with the pharmacology. We did an Azra presentation about this in the delayed spring meeting where we talked about buprenorphine. It's a really great panel, and I would suggest if you really want to learn more, go there. But I think I was the one that wrote the protocol for weaning that went national, and I'm also the person who's walking it back. And we have a letter to the editor that's floating around right now because others have agreed. I think there's a lot that's happened that makes that more feasible today. I think we've made a lot of advances in acute pain. Buprenorphine's now on formulary. Before it was not. So the idea of having people take a home controlled substance while in the hospital is really a harder thing to consider. And I also think that we have better identification and recognition of these people beforehand. So across the board, I think there's a lot of opportunity. It's a good drug. I think it's got an opportunity. I don't think it's the panacea. And I think its uses will be really broad for both chronic pain and acute pain, including, I do use in the pain clinic quite a bit, low dose transdermal for people with chronic pain. But no, to answer your more narrow, peri-op conversation, because buprenorphine could be a whole podcast, maybe it should be. The peri-op conversation, I don't recommend weaning people anymore and especially certainly, and there is an ABA question about this that is wrong. Just there's a MOCA question out there that says you're supposed to wean people before surgery. I almost fell over, and this is a person with clear opioid use disorder. I almost fell over when I read it because I think they're misinterpreting the policy that I wrote. We never intended to wean people with opioid use disorder off. That is a conversation. And this talks about transitions of care, which we just mentioned, the idea of getting the preoperative usual prescriber involved earlier on. That's the rationale for doing this. This is a perfect example of how coordinated care is critical.
Yeah, the one comment I was going to make for this youngin' Ketan was that I remember nearly 20 years now, Chad, in residency, one of our attendings singing the praises of buprenorphine, and we didn't know what he was talking about back then. I don't know if you remember Dr. Dorji singing that down the hallways. But
buprenorphine. I remember George probably still sings it. He's still over the VA, and he probably still sings it. What a lovely guy.
So he knew something we didn't know. I didn't know what he was talking about back then, but it seems to come back around. But Chad, I want to thank you so much for joining us. This conversation could go on and on and on. We've got Dr. Shah waiting in the wings for another portion of this conversation, but you've given us some great ideas for future shows, and I think we'll bring you back on for some of these topics and then and flesh them out a little bit more because they do deserve a lengthier conversation. You're welcome to sit around and listen to the next part of the conversation, but we're going to move on to Shalini and get her started. But thank you, Chad.
We'll give her my best. She's great. Thanks so much, guys.
Great seeing you, Dr. Brummett.
All right, let's bring
Wonderful.
Dr. Shalini Shah on.
Great. So our next guest is Dr. Shalini Shah. She is the Vice Chair of the Department of Anesthesiology and the Director of Pain Services at the University of California, Irvine. And she's also the founding director of one of the largest ambulatory pediatric pain services by volume in the United States, as well as the new integrative pain services at the University of California, Irvine, which I did my undergrad at. So it's a pleasure to talk to you, Dr. Shah. How are you doing today?
Doing well, thank you.
Of course. So one of the things that you were in the lecture in the Azra conference titled "Alternative Treatments for Chronic Pain," and one of the things that you've done a lot of work in is Botox in migraine patients. And there are a lot of listeners out there who maybe don't see a whole lot of migraine patients, or just tend to refer them to neurology because they're not, too sure what to do. At U of M, we did a lot of Botox, but where I work now, we don't do any. So maybe you could just give her like a small primer on Botox. Who are the candidates and how you utilize it in your practice?
Sure. I know we're doing disclosures first, and I know it's not a CEO,
absolutely. Yeah.
but I am a consultant for Allergan, who's the producer of Botox, as well as for SPR Therapeutics in Massimo. So for Botox, I personally find that headache medicine is one of the most rewarding types of chronic pain practices to manage, just because they do so well when you get them on the right therapy. And I think that Botox is one of them. It's not for everyone. So a patient comes in with episodic migraine, less than 15 days a month, they probably are not going to respond or not responding well. But you've got those patients who have chronic migraine, 15 days a month of headache days that are debilitating. They've tried a lot of the PO medications without much efficacy, or they can't tolerate the side effects. And Botox is a really, really great preventative option for them. It doesn't cure them of migraines. They're still going to have migraines, but at least they don't have as many symptoms throughout the month, or they're not going to have as much severity with their migraines. It's not going to be as debilitating. And it's pretty easy to do. Once you get into the fold, when you did your fellowship, once you get into the fold of injecting, less than 2 minutes of your time to inject, and these patients love you. And that's actually one of the things that we saw during the COVID pandemic, is that I could keep my low back patients away. I could keep my neuropathy patients away, but the migraine patients were knocking at the door. They would do anything just to come in, just to get their Botox.
Yeah, and it's not a very difficult procedure by any means. It's a lot of, maybe little injections here and there, but it's you're right. They were so happy to be there, and it was very fulfilling. Yeah. Great. And then one of the other things that you talked about in your lecture was this term called sarcopenia. I had never heard of it until the lecture. Maybe I should have. But essentially what it means is it's muscle atrophy. And I think it's pretty intuitive that muscle atrophy can be associated with increased heart disease, diabetes, decreased testosterone, and increased inflammatory markers. And, obviously in chronic pain, we have a lot of patients who could, serve to move a little bit more, exercise a little bit more. And it's hard to sort of make that connection with people with their overall health equating to their pain control. Because you tell someone, work out more. It's very easy for us to just say that, but then people will say, well, if I work out, I'm in pain. And then you're just stuck in this sort of trap. How do you sort of approach that conversation with people and relate their overall health to their chronic pain, and how they can work hand in hand together?
So going back to the term sarcopenia, the reason I brought it up in the lecture is because it's a pathophysiological marker of aging. And aging, as we know, is associated with pain. And what people may not know is exactly what you just said, Ketan, is that with sarcopenia, which starts in the 4th decade of life, so once you hit 40s, you're going to have a 10% decrease every decade. But what that really means is that the muscle mass, and I'm pointing to my muscle that's really not there, the muscle mass that that decreases is now replaced with adipose, right? So that's why you see your insulin sensitivities or resistance. That's why you see your hypertriglyceridemia, all those things, heart disease that's associated with aging. So that's one of the things that I like to tell my patients, is that, the importance of exercise is not just functionality. It's not just the joints. It's not just the soft tissue, the tendons, but it's really to prevent as much sarcopenia as possible. Yeah. Go ahead, Ron.
Yeah, we've actually been talking to a lot of our preoperative patients as well, and recommending supplementation of protein intake and mild, even light weightlifting. And these are patients with severe, some of them with severe limitations due to chronic pain or chronic illness, and helping them understand that even light, small changes make big impacts in their overall health. And then we're particularly looking at their perioperative morbidity and mortality. And there's good evidence to show that changes in sarcopenia or detection of sarcopenia is related to outcomes. We have this, Chad mentioned it on the first part, this early recovery after surgery. Well, one of the main parts of ERAS, early recovery after surgery, is getting up and moving. Mm-hmm. every little change in muscle tone, muscle mass is directly related to your ability to get up. And when we know that every day that somebody spends in bed after a surgery, they're losing muscle mass daily, not even yearly, like you're talking about with the regular aging, but daily in the hospital. The more you have at the beginning to give when you get to that place, the better chance you have of meeting that early recovery requirement of getting up, moving, walking, and doing those kinds of things. Related to the question of sarcopenia, have you been hearing or talking about any of these imaging studies that are looking at how to measure sarcopenia using imaging modalities? There's some stuff I've seen on using, obviously you don't want to use CT scans on everybody, but even using ultrasound as a technique for measuring amounts of sarcopenia in patients as an assessment tool.
That's a really great idea. I just don't know how it would fit into the predictive algorithms that we have right now, or the preventative algorithms that we have. Who's going to pay for this? How does it get covered? But again, this is it's a whole different podcast, but this is one of the problems with the current U.S. health system, is that we don't really incentivize these types of tests to see where we are in body habitus, muscle mass, things like where we can these are easy things to optimize. It doesn't take rocket science. It doesn't even take a medication to optimize muscle mass, And that actually brings me up, I don't know if it was on Twitter or where it was. I saw a question that was posed from one of the pain physicians, and says, we do a lot of pre-op optimization about heart and lungs and things like that. Why don't we, as anesthesiologists, ever take the role of pre-optimizing pain or functional recovery, getting the patients ready? We talk to them pre-op in our pre-op clinics, but we hardly have the conversation about pain or what you need to be doing, what kind of diet you need to be on for the week or 2 weeks preceding surgery. These are all the same things that I personally think the anesthesiologists, we should be taking a better role in, or bigger role in.
We actually, at Vanderbilt where I work, we actually opened up a special clinic. Right now we carve out the high-risk patients. And so these are patients that have multiple comorbidities or high-risk scenarios. And I mean, we spend about an hour in clinic with them, and assessing all their medical comorbidities, but also prescribing treatment, anemia management, vitamin deficiencies, nutritional consults. I mean, we had patients, I'd spent 3 days in clinic this week with those patients, and we have a nutritionist basically in the hospital. And if I call a nutrition consult, they'll see them before they leave the clinic, and they'll come down to our clinic and see the patient in the room. It's been a labor of love. There's been a lot of people put a lot of work into it, and it's clearly an investment by the hospital in improving the care for these patients, because this isn't something that's recognized or well rewarded in our current, or incentivized in our system, but we know that it impacts the care of these patients. And so we've had about 18 months now of this clinic, and it's been going pretty well, but it's a lot of work.
Yeah, it takes a village to do all that type of thing. You need a lot of different consultants and physicians and nursing staff and things like that. And it can be very difficult, especially in like a private setting. And I think you touched on the fact that it's so important to explain to people why they need to do these things, right? Like, why do you need to lose weight? Why do you need to eat better? Because it can be frustrating as a patient going to a physician. They're just like, hey, you need to lose weight. And it's like, yeah, I already knew that, but can you help me figure out how or why? And oftentimes that's not really explained to them in terms of why they need to lose weight and how to do it. And speaking of diet in general and weight loss, there's a lot of diets out there, right? And you touched on a few. Did we lose her?
I am back. Can you hear me?
No problem. Yeah.
Sorry.
Yeah, no problem. We were just talking about diet, and you touched on a few diets in that lecture. And as a patient, it can be kind of confusing, right? There's the keto diet, there's a Mediterranean diet, there's a diet called the Elimination Diet that you brought up that I honestly had never heard of, and I had to, maybe that's my own naiveness, but I had to look that up after the lecture. And so, pretend I'm your patient, doctor, I want to lose weight. What do you recommend? I've heard of all these things. It's a little confusing, and I'm not sure what to believe.
So the diets that I brought up, particularly, I'm going to go to the elimination diet. They're not really weight loss, but they're more to control your pain. So integrative options to control your pain. So the Elimination Diet, which is, a fabulous study showing that those patients who had chronic food triggers, which was IgG mediated, most allergies are IgE mediated, but this is IgG mediated. The hypothesis was that these IgG food triggers actually cause more pain via an inflammation cascade. So the thought was, if we eliminate these foods, and the way they do that, they do IgG sensitivity testing on various types of foods, and they tell you what you're sensitive to, and you hold those foods for about a month or 2 months. And those patients who held those types of foods had about, I would say, anywhere between 25 and 40% decrease in their pain syndromes. And this is mostly for migraine, because most of my work is in migraine, so I can only speak on migraine, as compared to not eliminating those dietary triggers. Then they took the study one step further, and they said, those patients who have migraine all fit the same type of profile. They're women. They have usually comorbid fibromyalgia, comorbid IBS, irritable bowel syndromes, the same type of patient profile that you see. And they said, well, let's see if we add probiotics and see if that makes a difference, because IBS is very strongly related to migraines and anxiety and depression and that female profile with migraine. So Elimination Diet plus probiotics had an even greater decrease in migraine symptoms than not adding probiotics. But adding probiotics alone doesn't do anything. So you have to do the Elimination Diet, which you eliminate those triggers. Typically, those triggers are dairy, egg white, chocolate, amines, things like that. And you eliminate those foods, as well as adding a probiotic to your diet. And that seems to help those migraine patients.
Oh, it's really interesting. I had never heard of it. Raj, had you heard of that before? I certainly hadn't.
Yeah, I mean, I know there's a lot of work being done on dietary issues with migraine patients in particular. As somebody who has suffered migraines in the past and actually had to visit the emergency room one time with a really bad migraine. Luckily, I'm blessed not having them on a regular basis, but I've had bad ones in the past. So much of it was diet and stress related triggers. And I mean, I can predict when I'm going to, if I've made some bad choices in what caffeine or chocolates, or, for me, wine was a big trigger, or red wine specifically. Anytime those things are gone, then the issue doesn't come up. And so, and I'm a mild case, and I've had friends and colleagues who are much more severe cases of migraines, and so it only goes so far. The Elimination Diet helps, but it needs that plus, and that plus. And so it's interesting to hear about what these additions are to kind of make that better.
And it's not for everyone. I have some patients who come in, Ketan, you've probably seen it too, who say, doc, before we talk about new medication or gabapentin or whatever, is there anything else I could do that I could make for myself a lifestyle choice? And I'm seeing that more and more and more. I don't know if it's because I live in California or if this is really a trend that patients really want to avoid pharmaceuticals and medications and see what other holistic approaches there are before going into, conventional Western treatment. And then I've got some patients who say, I've tried everything. Now can we talk acupuncture? Now can we talk acupressure? So it's a range of patients. Probably you've seen the same thing, Ketan, where.
Yeah, absolutely. And I have patients who will, and this kind of leads to my next question, because, this is something I've been curious about too. There's a lot of these like supplements, that are out there. Maybe supplement's not the right word, but things like turmeric that you talked about in your lecture, there's magnesium, vitamin, B, D, C, what have you, and it's hard to, I struggle with just blanketly recommending that to everyone. I don't want to be that, because sometimes I'm just like, you should take turmeric, and I'm not even sure, is it the right decision? It's a relatively safe medication, right? Medication, if you can call it, it's almost like a food spice type of thing. But, I wonder if you can just talk about a few of these supplements that maybe you recommend, what, their indications are, and if these things are safe to just say, hey, take it and try it.
Yeah.
Hey, Shalini, before you answer that, we got 3 Indian people on this show. Yeah. You can just tell them to eat Indian food. And you got turmeric, ginger, you got some garlic in there. You pretty much got most of the stuff that you need. It's what my mom's been saying since I was younger, right? She's been trying to feed me that since I was a kid.
Yeah, because they know it really does work. So turmeric, yes, there's a very, very high upper limit for toxicity. So I'm not too worried about recommending it to patients because it is a very, very, very good anti-inflammatory agent. Now, the problem, Ketan, that we see in our patient clinics is that there's a lot of hand waving going around, right? When patients come into you and they say, "Doc, should I be taking vitamin A, vitamin D? What do you recommend?" And historically, we all say, "Yes, go ahead and take it. What's the harm?" There's not much toxicity involved with it. It can only help, right? But one of the things that I try to learn about personally is to know what the molecular mechanism is of these agents and why they would help. So you can have a really frank conversation. So vitamin D, I wasn't aware that vitamin D is such an anti-inflammatory agent. And we see it now in the news because of COVID. A lot of health systems are recommending vitamin D supplementation. And I wasn't really aware of the mechanism apart from calcium and bone uptake. But it's a very potent anti-inflammatory agent. In fact, I just read an article that said the #1 ordered lab test among CMS beneficiaries last year was vitamin D. Most physicians are ordering vitamin D levels on everybody and anybody. And what they're finding is that most patients are low in vitamin D, even those who live on the West Coast where there's a lot of sunlight, because vitamin D is absorbed through the torso, through the sunlight, through the torso. And we're even in the West Coast, we're always covered. So even if you live in a sunny area, doesn't mean that you're going to be full of vitamin D. So a lot of patients are taking vitamin D supplementation because they're finding out that they were low on it. And it's very helpful from an inflammatory standpoint, and it looks like from an immune modulation standpoint as well.
Yeah, vitamin D is one of our common, I mentioned that clinic before, that's one of our common orders and it's surprising, at least half our patients are deficient, is in vitamin D levels. And so we've been ordering them almost consistently. And even the patients that have really good care from pre-surgical or surgical teams before they get to us, that's one of the few things that they don't order. And so I think in our surgical arena, we haven't looked at vitamin D as much. In the medical and particularly the cardiac arena, all the heart doctors are looking at vitamin D levels for all their coronary disease patients now. And it's actually become almost a standard for one thing they have to keep track of, just like cholesterol, just like blood pressure, is vitamin D levels.
And so if you order vitamin D, if you notice your pre-op patient is low, you can start supplementation even a week before.
Yeah, and you can give them, you can do a catch-up dose, 50,000 units as a single pill prescription, and then have them just maintain it. One of the goals of our clinic is actually, yes, there's some things that we can do to get them optimized for surgery, but we're also taking it as an intervention opportunity to make somebody better for their long-term health as well, and just looking at them from a global perspective, which even some of our internist colleagues don't have time to do and look at all of that detail. So we look at it as an opportunity that even though, yeah, this may not impact their surgery, there still need to be on, iron supplementation or vitamin D supplementation, or they need a evaluation for sarcopenia, and, we can't delay surgery, but this needs to be started at least. Smoking cessation, it's not going to solve all their problems, but at least that conversation needs to be started. And then, believe it or not, and you guys who have ever worked in an operating room environment, we actually have surgeons that will allow us to delay the surgery if necessary, to get somebody better. So we have actually delayed surgery several months sometimes, because the surgeons are starting to recognize that we actually make people in better shape and actually reduce their complications rate post-operatively. So getting them fine-tuned when delay is possible is actually in the surgeon's best interest as well as the patient's best interest. So it's taking a little bit of convincing, but more and more of them are coming to that realization.
Wow.
But it's hard work.
It is. Yeah. Convincing a surgeon to put something off is a tough hill to climb. But
and again, it's everybody's best interest at that point. And again, you're looking at outcomes as the way of showing people that. Hey, Shalini, before we wrap up, I want to go back to the first topic that we talked about, was the Botox. I thought that was really interesting, is help people understand, and for me, who's not a chronic pain physician, help me a little bit understand is with these injections, where are you injecting? How frequently are you injecting? And what is the trade-off compared to what else people have been doing in the past? If they're getting injections, are they stopping certain medications? Are they going to the ER less? Are they having reduction in escalation to more advanced therapies or something like that? What is the value add for those procedures?
Mm-hmm. Yeah, so the way Botox works is it inhibits acetylcholine release at the receptor. And it's 31 injection sites. They're pretty quick to do. Over 7 muscle groups. The procerus is the first one. We've got the corrugators, frontalis, your temporalis, occipitalis, and your cervical paraspinal and your trapezius. It's, like I said, pretty benign. It's not very painful to do. You get about 12 weeks of relief. Because that's the point at which the toxin disassociates from its receptor. So it's not a permanent procedure. They do have to come back repeatedly every 3 months for re-injection. And typically the sweet spot is about that 6-week mark where the toxin is fully bound to the receptor. And that's when you want to come back and evaluate the patient to see how much relief they get. And it's not about pain relief. And that's what most of the patients will tell you. They'll say, Doc, I'm very happy. Thank you for the pain relief. But really, they're back at work. They're not as disabled. They're doing their daily activities. They're interfacing better with their public or with their families. And overall, they're happier. And that's what you see. They're just overjoyed. They're the patients, like I said, who are so happy to be in the doctor's office that day because it just makes that much of a difference. And yes, you're right. They're not going to the emergency room. They're not getting their ER drug cocktails as often. So there's decreased healthcare utilization from that standpoint. But also, they're able to wean off the medications. Doc, maybe I don't need topiramate anymore. Maybe I don't need my propranolol or calcium channel blocker anymore. So you're able to wean off the pharmacotherapy as well.
I just don't want people to confuse the Botox term is associated with cosmetic relief, and I don't want people to confuse that as the same thing. It's a drug just like any other drug, and it's being used for a purpose that has larger benefits to patients beyond what the superficial impression some people might get. And so I wanted people to hear that return to life, that return to daily activity, that return to not having to hide in your dark room by yourself and your family's outside is so impactful to people's lives that, if you change the name of the drug, you would think it was a miracle for patients. And I want people to be able to separate those two. That happens with a lot of different drugs that we face. As we were talking with Chad, he mentioned it quickly was methadone. Methadone also has a context associated with it, but it has very powerful and good uses in the right circumstances. And so people often confuse methadone with its historical context and not necessarily its current use case. And I think it's important for us as clinicians, but also patients who hear this to understand that that's a difference. And it's an important distinction, even though the names may be the same and the drugs may be the same.
Yeah, well said. So
well, I want to go ahead,
just
Shalini,
ask one
please.
question? Because I'm really fascinated with your pre-op evaluation clinic. On the post-op side, do you do anything holistically for post-op pain management, meaning acupuncture or Reiki or naturopathy?
So not yet. What we've started to do is for those patients who are high risk or that we're concerned about escalation of acute on chronic pain, we do facilitate the admission to our or follow up with our chronic pain group. And our chronic pain group has an integrated health system association. So we have both an integrative health part of our hospital and then the chronic pain group, which is primarily interventional and medical management pain. And so these teams all work together. So when a referral is necessary from one to the other, we kind of do that, but we take each patient as an individual and we don't have blanket therapies for that yet. We've recently started supporting a transitional pain service so that bridge from hospital to outpatient care is really well handled. Because I think that's the moment where someone either deviates into one direction or the other, is if that few weeks of transition between leaving the operating room, leaving the hospital and kind of maybe having follow up with your own chronic pain physician or a new chronic pain physician, there's a period of time where every day can matter. And decisions that are made at that point can lead people. So we're kind of putting our emphasis on that transitional pain service. If when they get to the chronic pain clinic, they need an integrative health kind of evaluation, there are opportunities, but it's not a standard yet. Those are still openings down the road. Lots to do. I mean, our protocols for that clinic are so extensive. We have about 12 different algorithms for body systems. It takes me, when I write a note for that clinic, it takes me about 40 minutes to write one note.
Yeah.
Because we look at every system of their body and kind of come up with a plan for everything. And so we keep adding new things. And so I don't think that's going to finish. The patients those patients are complex, and we're one of the first people to actually listen to all those things at the same time.
Yeah, and the way I look at it is, an anesthesiologist, you're doing the same job, whether you're in a pre-op clinic or whether you're in a pain clinic. The mentality and the mindset is the same. It's just the location is different. So seeing the patients, having pain management, seeing the patients pre-op, we're doing the same type of assessments that a pre-op clinic would be doing.
Yeah.
And it just makes sense.
Well, our biggest inspiration was that, we often evaluate patients before they go into the operating room. I mean, we do that daily, and we'll detect things about their medical history, and we're frequently going, man, if I only had 3 or 4 weeks,
I know
I could have made a difference. So that's what this is, right? This is that 3 or 4, maybe longer time period that we can get to the patient, see the problem, and do something about the problem before they get to the operating room, when it's almost too late at that point.
Yeah.
So, I don't mean to deviate into that part of the conversation, but your conversation about sarcopenia, I think, is probably, and the comment and conversation about frailty kind of ties together with your nutrition and diet and muscle tone, all of that, which relates to chronic pain, also relates to overall perioperative care. I think that's going to be a big part of what the next decade looks at for patient care in the surgical and chronic pain arenas. And I think people have been clamoring for it for years. We just weren't ready to do something about it. And I think we're starting to.
Or having a discrete physiological marker to measure or to level out, are you ready for surgery or not, apart from cardiovascular and pulmonary.
Yeah, this is one thing that I think frustrates the general public about medicine, is that we need quantifiable in medicine, and scientists, we like quantifiable metrics and things like that. And until something is quantifiable, it's hard for us to get on board with the concept. But, our patients have been telling us for years that this thing that I eat or I don't eat makes a big difference. Or, yoga has made a huge change in my life, or acupuncture. I mean, for years they've been telling us this, but we didn't know how to embrace it. And I think that we're a little bit behind. Hopefully we can propel it forward. But I think as physicians and scientists, we have to embrace that and understand that just because we don't fully grasp everything that it's doing, that doesn't mean that we shouldn't consider it as reasonable.
Yeah. And, that's one thing I feel is missing in medicine today, is accountability of the patients. And that's one thing that I've noticed has made it such a big difference by using these fitness trackers and iWatches and health apps, where patients now feel accountable for their own health care. And if you come into pre-op clinic with a sarcopenia score of XYZ, and then you work on it, and you come back 30 days later and you see the improvement, gosh, they feel validated as well, that all that effort that I put in made a difference. And I'm going to keep working at it because I saw the difference it makes when you put effort in, instead
Have you heard this? Have you heard this phrase, the quantified self?
No.
So that's the phrase of the current tech bubble, is that all these little things that we're doing, my watch is measuring my heart rate, my oxygen, my steps, my activity, I'm quantifying myself. Which is what medicine has been doing for a long time, is trying to quantify people. So this is now people can quantify themselves. If you're diabetic, you get continuous glucose readings. If you have one of these little patch things on your arm, there's probably in the next 4 or 5 years, we're going to have blood pressure on my watch. So I can tell my blood pressure constantly and trend it throughout the day. We're going to be living in a quantified self. The question then becomes, what do we do with all that data? And how do people leverage that? And I think, it's interesting that the technology world is kind of embracing that and doing stuff with it. We have a friend of ours who works, was a University of Michigan anesthesiologist who actually works for Apple in their watch division and health stuff. And, he's putting this into action on the technology side, looking at how to quantify the self. Anesthesiologists are the quantified people for a long time. We've been looking at number trends in real time for a long time. Now we're giving that to people to do on their own, so it's going to be interesting how all this stuff comes out. Who knows, there may be a strap you put on your leg that can measure your level of sarcopenia at some point. Who's to say that doesn't exist in 10 years? And then you can see that trend over time, instead of measuring just weight, but actually measuring muscle mass and tone and composition, which probably is more accurate. So, but that I think is going to be an interesting part of the next 10 years. So,
Absolutely.
But that's deviated a little bit from where we started. We could go on and on and on.
That's a good deviation.
Talk. Yeah, it was good.
Yes.
Yeah.
Shalini, thank you so much for joining us. It's always a pleasure to talk with you. Hopefully we can all see each other in person sometime soon. I think everybody's craving that.
Somehow. Thanks again, Dr. Shah. We really appreciate you coming on.
Thank you, guys.
All right, guys, we're going to wrap that up. And again, I want to remind everybody, go to Azra.com. And if you want to get up to date on Azra's meetings and information about upcoming events, that's the best place to find it. And we usually have a feed of information coming right there. So check that out, and we will see you guys at the next podcast. Thanks, Ketan.
Everyone take care. Good seeing you, Raj. Take care.
All right. Bye.